Our third speaker, and hoping I'm saying your name correctly, is Dr. Jason Efstathiou. Okay. He's going to talk about the comparison between IMRT and Proton in prostate cancer.
Thank you very much, and that was a nice rendition of my name. If you sneeze, you get very close. So I'm going to try and tie together a number of talks that you've heard, and to follow up on Dr. Steinberg's talk, trying to look into the issue of the type of data and evidence that's needed to inform a value, and then also in particular, collaborative models to get those kinds of studies done that are needed. So we've heard this before, but some have suggested we're living in a state of gizmo idolatry, the human love of bells and whistles, heroic exploits, proof of competence, perhaps sometimes minimizing risk. And indeed, I'm stealing this from a slide from Dr. Zeitman, who you heard yesterday, who gave us the new technology and enthusiasm curve. So indeed, I think a lot of this meeting has focused on this, which is a new technique or technology or treatment is introduced, a celebrity is treated or it's gaining hype, it's the best thing since sliced bread, and then you wouldn't give it to a dog, and eventually you figure out appropriate use. And our real job here is to smooth that adoption curve with appropriate evidence. We're also subject to a lot of direct-to-consumer advertising and sometimes direct-to-provider advertising, as this provider ownership ad actually shows. If you read the fine print, IMRT has the sharpness of a surgeon's knife and the softness of an artist's brush. So I'm going to use as a demonstration prostate cancer. Prostate cancer 20 years ago was conventionally delivered. This is orthogonal films, and 20 years later has exploded to a variety of different options, 3D IMRT, proton beam, SBRT, combination of all of the above. Why did this happen? How did it come to this? Indeed, there is in fact a local tumor control problem with radiation therapy in prostate cancer back in those days. And the solution of our field was rather simple. We just increased the radiation dose. And in fact, our field should be credited on running many large randomized trials proving these sorts of points. In this case, 5 randomized trials, all showing significant benefit to dose escalation in terms of disease control. For about an 8 to 10 gray increase in total dose, there was up to 20% benefit in freedom from biochemical failure. This is one of the latest updates from one of those trials showing, again, significant benefit to higher dose radiation. When we looked at issues of toxicity from that study in particular, we looked at significant late GU toxicity between the low and the high dose arms. They were equivalent. We looked at GI, they were also not significantly different. So indeed, it seemed like you could go to higher doses and get away with it. More importantly, if we asked patients how did they feel about it, and we looked at patient-reported quality of life outcomes, in the urinary, bowel, and sexual domains, there were no decrements, in fact, to dose escalation per the patient. So we've gone from, and I'm going to summarize a little bit of what you heard yesterday just to put everything in context, but we've gone from 2D radiation, what's called the 4-field box, to, in the 1990s, 3D conformal radiation, angled beams using CT scanners to guide the design of fields. To, in the early 2000s, IMRT, which is really using inhomogeneous beams to sculpt around critical structures such as the rectum. And we've even introduced what's called image guidance, because in fact the target that we're trying to treat every day moves. These are serial CT scans of a patient's prostate throughout the course of 8 or 9 weeks of radiation, demonstrating that dependent on rectal and bladder filling, the prostate in fact moves not insignificantly. So, as we've gone through this technology, we have improved what's called dosimetry. The amount of dose going to critical structures, high dose going to critical structures, has been reduced significantly. Those in and of themselves are not a clinical outcome. But if we look at some prospective studies and we look at them retrospectively and we look at how much of that rectum got that high dose or higher, in fact, there is a significant benefit to limiting dose to organs such as the rectum in terms of later rectal toxicity. There's been one prior randomized trial of technology in prostate cancer. It was 2D radiation versus 3D radiation. It was run in the UK, and it in fact showed a significant benefit in terms of avoiding proctitis with the more advanced technology. What we know, though, is that IMRT has taken over 3D, and the requisite evidence, those kinds of randomized trials were actually not run in prostate cancer with IMRT, but as we know, IMRT use has exploded and is now pretty much accounting for the vast majority of prostate irradiation in the country. And now, of course, proton therapy, and we've heard some about that, with promises of potential better tumor eradication by potentially being able to go to higher doses and possibly reduced morbidity. So you saw some fancy cyclotron images yesterday, so I'm going to tell you actually what's behind all that. If you mix a little holy water and you have an electric eel and some blood, sweat, and tears, some magic smoke, poof, you have protons. So that's actually how it works. But you've seen this map way too many times now. But there are 18 operational proton facilities, and of course that's doubling over time. So the physics, again, just a quick primer from yesterday. There are pristine, what are called Bragg peaks. The radiation dose goes to a certain depth and stops. There's no exit dose. So in fact, you can treat a tumor at a depth such as the prostate of 20, 25 centimeters into the body and no exit dose. So the clinical potential is real. And again, some images you saw from Dr. Zeitman yesterday. But in pediatric medulloblastoma with protons, you can avoid all anterior structures, the bowel, the lung, indeed the heart. And that leads to way less significant late effects and morbidity, less second cancers as well. So what about prostate cancer? Well, this is proton beam delivered with 2 lateral beams for prostate cancer, a number of angled beams used in IMRT. If you minus one out from the other, this is in fact what you get. So the prostate here in the middle is gray because it's getting the same dose. There is not expected to be any survival or disease control difference if you're delivering the same dose to the target. What there is, though, with IMRT is this low dose pelvic radiation bath. And the question is, does that lead to less fatigue, less second cancers, less bowel effects? And that's sort of where the crux of the question is, at least in the case of prostate cancer. So we're actually, in fact, irradiating liters less of whole body tissue with proton beam as compared to IMRT, but it's in the low dose range. And the question is, does that have clinical impact? In fact, proton technology has advanced even further. There's now what's called beam scanning technology that is kind of the equivalent of IMRT to 3D that we saw earlier. And indeed, planning studies looking at the dose to the rectum, comparing IMRT in red, 3D conformal proton beam to intensity modulated proton therapy, again showed dosimetric benefits to this advanced technology. The question is, does that translate into clinically meaningful outcomes? There's potential for this sort of technology, the scanning technology, to perhaps differentially dose a prostate and using imaging define a tumor nodule that goes to even higher doses and attempt to spare normal tissues even further. And there's also the possibility of using more creative beam angles as opposed to just your 2 lateral beams, which is the furthest distance that going through hips. Perhaps you can use anterior beams if you really get a handle on this technology. There's a number of prospective studies run by institutions such as University of Florida. They're non-comparative, but showing that patients over time from baseline to 4+ years later actually didn't have major decrements, maybe some moderate or modest bowel decrement over time, but otherwise overall did well with this sort of therapy. So the question is, does proton beam carry less morbidity, in fact carry less morbidity in the treatment of prostate cancer? And despite some of the theoretical advantages of proton therapy that I showed you, studies have yet to show a clear clinical benefit when compared to IMRT. So if we go back to the lay media, in fact, Men's Health wrote an article on proton beam calling it the magic bullet for prostate cancer in 2011. It took them only 1 year later to write that the magic bullet has indeed fallen short. And this was in response to a SEER Medicare study suggesting more bowel side effects with proton therapy when compared to IMRT. There's a lot of problems with SEER Medicare studies. I mean, billing codes are a coarse measure of toxicity and patient outcomes. And indeed, SEER Medicare studies don't collect a lot of important information such as dose and target margins and other things that we need to be able to interpret those kinds of results. And of course, they're subject to misclassification and selection biases. And in fact, some of these studies aren't necessarily consistent with one another. Dr. Yu, who presented yesterday, had a very nice article in JNCI showing the potential for some short-term benefit in the GU domain with proton beam when compared to IMRT, but no difference in the bowel domain, so not consistent with that other SEER Medicare study. Indeed, these results did not, they appeared to be transient. They didn't, in fact, hold over time. Other attempts to retrospectively look at prospectively collected patient-reported outcomes from 3 studies have suggested perhaps there is an early decrement with IMRT in the bowel domain and not so much with proton therapy. But the point of showing you these studies is that these retrospective studies are inconsistent with one another and the results are mixed. And as Dr. Beckelman showed yesterday, there are now a number of randomized controlled trials that are happening in our field assessing protons versus photons. Here are 3 of them. I'm going to focus on one, and Dr. Digman's going to talk about 2 others, the lung study, and there's in fact a CNS study as well. So let's look at the prostate study. It is a randomized controlled trial. Accrual goal is 400 patients, randomized the same dose, IMRT versus proton beam, in low intermediate risk localized prostate cancer with patient-reported quality of life as the primary endpoint. Very robust cost-effectiveness analysis endpoints as well, and others. So the primary endpoint of this study is to compare the reduction in mean EPIC bowel scores, a validated instrument, for men with localized prostate cancer at 24 months. So we are, in fact, looking for robust outcomes over time. Secondary objectives include looking at other domains, the urinary and sexual domains, perceptions of care, issues of satisfaction and regret, and other adverse events. And then very robust cost-effectiveness endpoints, also attempts to develop predictive models between radiation dose distribution and patient-reported outcomes, biomarker work, and other longer-term disease outcomes and late effect assessments. This is the map of participating centers. So this has required a significant collaboration amongst a number of centers that are academic and private. And so it's credit to these centers for doing this work. Indeed, the study has been activated at the Mass General Hospital, University of Pennsylvania, MD Anderson, Washington University, Northwestern Medicine with Chicago Proton Center, and Princeton Radiation Oncology. It will also soon be activated at Memorial Sloan Kettering, University of Washington Provision Center in Knoxville, and Rutgers Cancer Institute of New Jersey. And when their proton facilities are up and running, Mayo and Maryland will be joining as well. So this is, again, a significant collaboration of a number of the facilities that can deliver both proton and photon therapy. A lot of strong collaborations there. In addition, all of this requires robust credentialing and the ATC supporting centralized and standardization of treatment plan review and archiving. A lot of other efforts in outreach. One point I want to make is that the majority of these patients, 96%, have consented to release of health insurance records. So we are, in fact, collecting direct medical costs, insurance claims, and healthcare utilization data over time, not just at the point of care, but over time and follow-up. So I want to use all of that to highlight a couple of important points. There are a number of factors that influence accrual to studies such as these in technology assessment. One is the use of other management options. 36% of eligible patients from all the centers have in fact been randomized. That's an impressive number. 50%, however, have elected protons, 5% have elected IMRT. And here's an important number. 29 eligible patients who were otherwise willing to be randomized had their coverage denied, their insurance coverage denied for proton therapy. If you add that to the 107 who've actually been accrued to the study to date, that means over 20% of patients who are willing to be randomized cannot join these trials due to insurance denial. If we look at actually the three most common insurers currently covering 76% of the enrolled patients, Medicare, of course, is the majority. But Blue Cross Blue Shield, 21% as well. And I'm going to now focus a little bit on Blue Cross Blue Shield. The threat here is if a lot of private insurers and other insurers of patients under the age of 65 don't cover therapies such as this, the results of studies like this are not necessarily generalizable. They will be focusing on older populations and perhaps not on the younger populations where some therapies such as proton therapy may have benefit. So let's focus on Blue Cross Blue Shield. This is, in fact, Blue Cross Blue Shield of Massachusetts medical policy on charged particle therapy. Group 1, they get covered. That's the pediatric patients, ocular melanomas, etc. Group 2, this section defines conditions that are still under investigation and would be covered when part of a IRB-approved clinical trial registry or both. That is, in fact, in line with Astro's recommendations as well. So cover them, cover the treatment, full cost, cover that full cost if indeed you are developing evidence. And you see that prostate cancer is on that list of diseases that qualify for such coverage. So now that's a very proactive stance by a payer and perhaps a model of care and collaboration. So let's focus a little more on Blue Cross Blue Shield in Massachusetts. This is a summary of data that you saw yesterday. Basically, radiation oncology expense exploded from 2000 to 2010, and the main driver was IMRT. You heard that all yesterday. So, given this, Blue Cross Blue Shield of Massachusetts engaged a physician advisory council, a PAC, given growing concern about increased use of IMRT without quantifiable metrics. So they reached out and proposed a cooperative venture and reached out to 11 academic and private practices throughout Massachusetts. And those physicians met, those radiation oncologists met with Blue Cross Blue Shield leadership to reconcile these issues and develop a strategy to better define the use of IMRT with the overarching goal of achieving evidence-based use of IMRT in daily practice. So the credit for this work and these slides go to this group, the Blue Cross Blue Shield Massachusetts leaders and the PAC members. So initial discussions when these groups got together were centered on IMRT approval for specific diseases. And in fact, there was a strong consensus to cover IMRT if it was for localized primary management of anal, head and neck, prostate, and vulvar malignancies based on available evidence. Further guidelines were developed by the PAC based on a series of iterative deliberations using current NCI cooperative group normal tissue constraints from trials and the Quantec guidelines that have been published. And if the established constraints could not be met with conventional radiation, IMRT would in fact be allowed. So here is an example of that. So if with 3D conformal radiation, 50% of the heart was getting 30 gray or more with a 3D plan, but it wasn't going to do so with an IMRT plan, IMRT would be approved. So here is that policy. There's the no notification required, those diseases that qualify de facto, and then there's those that are covered by those guidelines and clinical exceptions where you just had to notify Blue Cross Blue Shield that that was happening. Then there are those such as with proton therapy where documentation of trial was required and coverage would be provided. And then there would be the usual submission and appeal process for cases that didn't fall into one of those three categories. This, in fact, got rid of a lot of ad hoc reviews and a lot of burden with that whole process, and avoided a lot of third parties. So this is what happened with this initiative in Massachusetts. During the 2 years prior to that program implementation, IMRT use had increased by 20% and conventional radiation had decreased by 3%. After implementation of this in 2011, there was a 17% decrease in the use of IMRT and a commensurate 6% increase in the use of 3D conformal radiation. That's sort of highlighted on this curve that shows that following the intervention, each data point below this, this is a process chart, below the extended control limits confirms the presence of a new process, i.e. IMRT utilization had gone down post-intervention. This is a relook at the SGR by Dr. Yu and his group at Yale, which obviously there's no cause and effect with the data and the model from Blue Cross Blue Shield Massachusetts that I just showed you. But actually, it does suggest that since 2010, there probably, in fact, has been a stabilization in the expense of radiation oncology. That plateau has likely been reached. So using 2002 data on the SGR plot, radiation oncology exceeded this, was 300% above SGR expectations. But using 2009 as a baseline, that has come right down to much more in line with what we would hope and expect. So, coming back to the Blue Cross Blue Shield Massachusetts collaboration, that really resulted in interesting findings. I mean, there was a consensus development of IMRT criteria, often in the absence of level 1 evidence. There was a significant decrease, as you saw, 17% decrease in IMRT utilization based on available evidence and consensus. There's a significant decrease in medical expenses. Blue Cross Blue Shield Massachusetts estimated that in the first year they saved $4.7 million. And there was flat administrative expenses. And as I said, you got rid of that third-party issue and ad hoc reviews. And there was a continued common platform for communication between providers and an insurance organization responsible for cost and quality of care. So this established a community standard of care in collaboration with providers. And it, in fact, may be a useful model for other new technologies where science is not mature and the clinical outcomes data is, in fact, evolving. So the Blue Cross Blue Shield Massachusetts leadership and the PAC continue to meet to update their IMRT guidelines and discuss utilization and guideline development of other advanced technologies, including stereotactic techniques and proton therapy. So just to wrap all of that up, in conclusion, external beam radiation therapy is, in fact, a safe and effective treatment. And in diseases such as prostate cancer, dose escalation improves cancer control without increasing the risk of serious side effects. I think we saw that early in the talk. Technology is great, but it can be seductive and it can be expensive. So that needs to be addressed. Proton therapy has some physical dosimetric advantages of IMRT, and we saw some data to that point. It can in fact spare some normal tissues and avoid the low-dose radiation pelvic bath in prostate cancer, decreasing integral dose. And in the right scenario, especially younger patients, pediatrics, that leads to decreased second cancers and late effects. Retrospective studies are mixed. We saw that. Ultimately, we need to continue to invest in and promote scientific innovation and creativity in medicine and in the field of radiation oncology while developing the requisite evidence to support use of therapy and looking to decrease cost. And in order to achieve those goals, I think we should encourage collaborative, proactive models of payer involvement, as you saw in the example of Blue Cross Blue Shield in Massachusetts. Appreciate your attention.